everyone. This is Dr. Nestor Rodriguez. Welcome you to another great session as part of this week's long sessions and conference. It's a pleasure to be here with you guys and a pleasure to discuss a topic that's kind of near and dear to my heart, both as an emergency medicine physician, seeing the downstream effects of it, but also being a professional within healthcare and outside of it, just kind of higher in the academic ladder, so to speak, and the challenges that go with that. Also here with a distinguished panel that you'll meet in a second, but today's session is on racial and ethnic disparities in mental health, access, care, and stigmas in our community. And for me, I wanted to put a little context to it. So we do talk about access, care, and stigma, and I think it's kind of the other way around in terms of stigma can influence sometimes the access and subsequently the care that's sought out or provided. And so, especially now with the pandemic, which has kind of highlighted the issues that come with mental health, more so, I would say, on top of social media also has highlighted these issues. It's an important topic that is just as important as finances, I would say, or professional development or networking. So hope to have an open discussion here with our panelists. Feel free for anyone that's listening to send in questions. We'll try to go either panel or at the end of the panel for sure. So first, I do want to invite and thank Henry and his staff for hosting us and for having this session, but also then for our panelists. I know you guys are all extremely busy, and I would want you guys to kind of introduce yourself, tell us who you are, where you're from, and then kind of go from there. So Karen.
Good afternoon, all. Again, my name is Karen Nelson. I use the pronouns she, her, hers. I'm the first EDI director for Rogers Behavioral Health. That's equity, diversity, and inclusion because we lead with equity here at Rogers. I started and was hired here about 10 months ago in January on Dr. Martin Luther King Jr. birthday holiday. And I came in bringing some 20 plus years of experience in the EDI space. First, in my first role, some of you watching may remember me as the first corporate diversity manager at GE Medical Systems, now Healthcare in Waukesha for all of the United States, Latin America, and Canada, all the way through to my most recent role. And others of you watching may recall me from the city of Appleton's mayor's office as the EDI lead there. I've joined Rogers' mission to help provide quality healthcare for those suffering with mental illness and addiction, with my goal being to improve our reach to diverse communities. Headquartered in Oconomowoc, we have 9 locations throughout the state of Wisconsin, from Appleton to Kenosha, and also in 11 other states from California to Florida. I'm so proud to be here as a member of the 2017 class of Wisconsin's top Black leaders from Madison 365. So thank you so much for inviting me here. And it's a privilege to be here to join this esteemed panel to promote health and wellness in our community.
Thank you, Karen. And Martina, if you can go ahead.
Yeah, good afternoon, everyone. My name is Martina Gollin-Graves. I'm the president and CEO with Mental Health America of Wisconsin. We're celebrating our 90th anniversary in the community. We're a statewide organization focused on advocacy, education, and direct service. And I'm really proud to be the first woman of color to ever serve in my role. So it's really an honor to sit here today and be able to have this conversation through the lens of a Latina. Thank you.
Thank you. And Pardeep.
Thank you, Nestor, and it's an honor to be on with Karen and Martina, and just want to thank Wisconsin 365, UW Credit Union, Henry Sanders. I said Henry Sanders. I've kind of merged you together, and just Wisconsin Leadership Summit. Congratulations on another successful year. My name is Pardeep Singh Kaleka. I am with the Interfaith Conference of Greater Milwaukee, and since we're 52-year-old organizations that has brought people together of diverse faiths to address policy, systemic issues. And as of recent, we've been addressing much more of some of the mental health issues that communities face. I'm a clinician by trade, so some of my work intersects kind of the faith work that we all do, encouraging our faith communities to be involved in public health, mental health work. Some of the work that I do as a private practice clinician is I work with a lot of families and individuals who are what someone called radicalized or maybe labeled extremist, or either they've gotten in trouble or they've been arrested or something like that. But some of the work that I do is help those families and those individuals exit the life of extremism. So that's a little bit about what I do, and I'm just looking forward to this conversation with Karen and Martina.
Well, perfect. And thank you, guys. And I would like to congratulate all of you guys, because there's a lot of firsts that are mentioned there and a lot of top positions too. So you guys are the leaders within these organizations that you guys have all mentioned have been around for a long time. And that kind of leads to the first question of, mental health and mental health issues have been around a long time, right? It's not a new thing. It's not because of the pandemic, all of a sudden, all this exists. But these discussions are more recent, right? And especially in communities of color, I would argue. And the question to begin with is, why is that? And why do you guys think, from your own experiences, both personally, if you want to share, or just, through your work, why is it that, mental health is kind of one of those taboo topics? And because of that, what kind of effects have you seen that it has both on children, community, and just kind of in general to our people? So if anyone would like to start with that.
I'll go first.
Okay.
Can I just put it out there, Dr. Rodriguez? Medical racism is a real thing. I'm just going to say it, plain and simple. Let me count the ways, from the Freedmen's Bureau to syphilis experiment, involuntary sterilizations, psychosurgery, that lobotomy where you actually take a part of people's brains out because they thought that was something. All of this started with this guy, Dr. Samuel Cartwright, in 1851, who thought that, I'm going to not even waste the word or misuse the term invented, but actually conjectured this term, droptomania. All of you clinicians could probably know exactly what I'm talking about. And he actually coined the term about and around runaway slaves, calling them crazy for wanting to leave the shelter of the plantation. And that was the beginning of 5 or 6 or so other physicians that then followed all the way through to this wonderful book that's out, where I got a lot of the stuff from, called Medical Apartheid, where it is still existing in our culture today, how it's permeated from the 1800s through the 1900s and right into this current century. So I am just so delighted to be on this panel with those of us who are looking for ways to figure out how to dismantle that, because not only did it happen to us as people of color, but we're also a part of the system where we are dealing with systemic racism on the one side, but also the white privilege on the other side. Like, oh, there's nothing wrong. We're just strong, and we've got the resilience in our culture, and we don't talk about these things. So we have some myths that we need to overcome. And I'm so glad that now, because of COVID, with us being concentrated for the last 2 years, we're able to really kind of open up this conversation and this dialogue with our families. So I just wanted to just kind of start things off with that historical perspective. I'm a history buff.
I like it. And it comes from somewhere, right? Because a lot of times we have to put, is there some origin to this, right? Is there some systematic thing? And then it kind of perpetuates into our well-being, right? Because we only know what we know or what we've learned. And it's not till we see other avenues or speak to other people where it's like, oh, I didn't think that was in, right? And in a light of social media and a pandemic, you feel like everyone agrees with you, and that's just not the case, right? It's not, we're not all the same people. So Martina, what would you say in terms of that question? And you're muted right now, Martina, so they'll mute you here. There you go.
Sorry about that, guys. I think that for a long time, physical health and mental health were seen as two separate entities. And so when someone walks into a healthcare system, for instance, the provider may just be focused on what's presented. And so I think that we have, hopefully, at least in the mental health world, we're really trying to help providers understand the importance of integration of behavioral health into the primary health care setting and what that entails. And so looking at other areas of people's lives and taking that into consideration. And so I think oftentimes it's really challenging for providers to look beyond that individual patient and provider relationship. And maybe there's lack of awareness, but also sometimes there's some fear about addressing some of those social determinant areas that impact people's health. And so then it also are people's own belief systems and values that come into play when we're talking about how we provide care to individuals. And sometimes it comes down to what people think people are worth and what they are worthy of receiving. And so there's just a lot in that question, and it's really hard to pick apart. But when I think about it through a mental health lens, where people often access help and services, oftentimes their primary or their pediatrician, and that's just sometimes a missed opportunity for such rich intervention. And so I like to say, what is it? An ounce, a pound of prevention is, worth an ounce of cure. I might have that backwards, but it's really something that we need to think about on the front end.
Okay. Pardeep?
I think Karen and Martina are right on. As far as looking at mental health, and especially in this country, we have to think about it from this country. And when we talk about mental health, oftentimes we're also talking about mental illness. So sometimes we use those words interchangeably, but within the history of this country, there's been systems that have been created that have been validated by our opinions about what somebody is worth, what somebody is doing. And, as Karen kind of pointed out, that there was this like over-evaluation of people of color and their pain being equated to craziness, meaning they must be insane, so there wasn't we've had it around for a very long time, but typically public health opinions directed towards people of color were used to kind of keep the system the way that it was meant to be kept. And then other people's pain was not treated the same way. And so there would be a kind of a sympathizing with one person's pain, but almost this like dysphomism used for somebody else's pain. And I think that's, and then mental health is very, it's not old. Only 50 years ago, we started to put into the DSM nomenclature PTSD. Before that it wasn't even there. And I would say, as new as that is to a lot of the white affluent community who was able to access those services, that's even much more newer to people of color who haven't had access to those. We still have systems of care in public health where 85 to 90% of the clinicians of the people that are employed or the researchers are white. And so there's this cultural gap of information that's missing to say and then there's disconnection. And that's not just in public health, that's in education, that's in other fields, that's in, as far as like law enforcement. All of these systems have an underrepresentation of people of color. And there's only a few people that are sprinkled to say, okay, how can I teach you to help service my community? But yet even teaching of something doesn't mean that that person is knowledgeable enough to actually do the work. Now you have to go back in and say, okay, there's nuances to this. And there needs to be continuous education. Maybe I'll jump into the last part of this of what do we do, but I mean, continuous education around cultural, like just gaps that we may have in our understanding. But I think that we're here right now because some of that has been used, again, to justify a system that's already been created to treat certain people, but to overly evaluate and criminalize other people.
Exactly. And thanks for those thoughts. And the reason I opened up with that question was one, to kind of see where our headspaces are, because this is a large topic, right? One question can lead to 100 different questions, right? And I think given our positions and obviously our experiences, but more so where we are in the work we're doing, we are at that stage of how do we make that access equitable, or how do we make that care equal across the board, right? And I want to go into that. And before I say that, I do want to also say, sometimes, and I've been a panelist and kind of heard I remember myself younger of, man, I hear this and I hear there's these inequities and I hear that there's this lack of access of care. And so two things are that. One, mental health and mental illness it's a perfect kind of distinguish, right? Because illness, and they are used interchangeably, like you mentioned, Pardeep, and that interchangeableness can also carry negative connotations at times to someone looking out in, right? So there's that fear of like, man, mental health is this thing that scares me, and tradition that's weak, or obviously that's consistent to help. Therefore, there's this fear to approach it or to get it. And I don't know if you guys have seen in terms of from your communities. I can just speak for my community, being an immigrant from El Salvador, growing up in a single parent home. That wasn't the avenue that my mom was like, go get help for mental health. It was, hey, you're not in a position, we're here, we have to make it and figure it out, right? Versus when I went to Yale for undergrad, man, my Caucasian colleagues like, we've been in therapy for years. Now, whether that's good or bad, if for whatever reason, but that's the difference of, is it for mental illness, meaning you have some biological, some hormonal component, something that a medication can help. And that's not bad, right? We've never looked at someone that has diabetes and said, oh my God, how dare you, right? But if we say someone's on for a medication for depression, it could be like, there's this stigma around it, which shouldn't be. But also mental health, meaning like, hey, if I can live every day happy, why is that bad? And if that requires me talking to someone like you guys every day, how is that bad, right? But it's been stigmatized where it's bad. And so looking through that lens, what would you guys tell people that are out there saying, before we get to the access and the systems, what would you tell me? I'm looking in being like, man, I do need help, but I can't. Nope, I don't want to step out there to get help because culturally I'm not supposed to do that, or I can't afford it, or I'm not. That's not my space. What would you guys say?
Mm-hmm. I'll start. I used to be a direct service provider years ago, and I think, and I worked primarily with families of color, and one of the things that was really hard for people to wrap their head around was this notion about mental health being on a continuum, good mental health all the way over to mental illness. And so I think culturally, probably the people on this panel right now, none of us were taught that. And that we all have mental health. And that's the piece that that's like one of my strong messages to everyone. It's about how we take care of it. And that's the part that's been missing. We've done a really good job educating kids and families about brushing their teeth and getting regular checkups, but we don't talk about mental health and wellness in the same way. And so that would be where I'd start, but I encourage us to think a little bit bigger and broader in terms of like a systems approach to that. So in the same way that we've put certain curriculums in early childhood and in school settings, some school districts do this better than others, but there is no consistency where we are teaching kids early on language to express themselves, how to identify when things aren't well, and then how to articulate that to the adults and the caregivers in their life so that they can go get help, right? Taking the stigma right out of that, saying, I'm not well, whether that's anxiety, depression, or I had a stressor or a life event. And then everyone saying, oh, of course, like your experience with your colleagues at undergrad, that just seemed to be the norm for those families, that they would go and get their child the help that they needed. And so I think in Black and Brown communities, we're not quite there yet. And I think sometimes, especially in Latino communities, school settings, we trust our teachers and who we turn our kids over to every morning, and they are really important in our lives. And so if we were to build that into a place that we trust, and we consider those folks trusted individuals, that could be a place to start.
Anyone else? Any other thoughts on
I
that?
just want to piggyback off what Martina just said, and I think that yes, that's, you know, as far as like having an integrated health approach, we need to have that, and we need to have it in early childhood education. We need to be able to teach a child how to be able to express themselves, and if they can't express themselves, give some options such as artistic programming, music, other programming that they don't have to verbally express themselves, but they can do it out of some other outlet. But having this, you know, if you're an educator, I was an educator for 14 years. I worked in Milwaukee for 14 years, and I would tell you right now, with as much information that is out there on the internet, on social media, there's just a constant bombardment of material. You do not need to be teaching your children, your students, about gathering material or memorizing something. You need to, every class, every teacher should be looking at it from a healthy social emotional report card. And the report card doesn't need to say A's and B's and C's, and just doesn't need to do that anymore. We don't need to test on like how proficient somebody is, or just find out how healthy are they socially, emotionally, and I guarantee you, you know, that will probably correlate to good grades or good whatever that is. And as we build a society, right now there's so much information that is out to the adults. And adults don't know how to decipher between good information and bad information. Thus, we sit here with this COVID pandemic. And I think that we need to start to build a foundation, and it needs to start with our young children. As Martina was saying, like, let's have an approach to say let's like be super heavy with the social emotional stuff, and let's be super like light with the math and reading, the other literacy programs. I know that matters, but no, it doesn't really. You're just fooling yourself. But you know, as we all go forward, I think that's the way to destigmatize it, and you know, again, modeling and saying, hey, listen, you know, here was my journey. Here's when I knew that I needed to get mental health treatment. I may have not looked, you know, like I had mental health or mental illness to the rest of the world, but I knew I did, and I knew how to listen to myself. And when I did listen to myself and I got that treatment is when it started me to the road, not towards recovery, but towards freedom. And that freedom was me getting to be myself and rediscovering what self is. That all needs to be taught in school. And you know, also within corporations and other entities as well.
Yeah, I agree. And you know, as we look at, you know, moving forward, then saying in terms of access, right, or put it into perspective, you know, for young professionals, senior professionals, or even corporations, right? There's the medical side, which I will get because there's a lot of health disparities. But before that, then there's also a perspective of how do we get mental health outside of just a diagnosis and being given a medication, right? I find it interesting that a lot of people, if you put the context of colleagues are like, man, I do professional development. I have a professional coach. If you literally dive into what that is, it's not like he's telling me go to A to B to C equals D, right? It's literally mental wellness. He's keeping you focused. He's keeping you from dealing from this is just noise to this is your well-being, or like when we say exercising or these things that it's funny how we gravitate in terms of like, I will pay thousands and I will feel I could shout it all out to everyone. I have a professional coach. Yet if you say I have a counselor or, hey, I'm seeking these services, they'll be like, whoa, yeah, that's not positive. Even corporations, right? All of a sudden you could say at work, I see it on the medical side, and I mentioned it earlier before the panel started, on a medical side, it's tough, right? You say I have mental health. Well, are my patients going to agree that they want to see me? Are they going to think like I'm not as good a clinician as someone else, or because I do a counselor? But I say professional development and professional coach, everyone's like, oh my God, he's got it. And so what would you guys say in terms of what other services, as we think, we have psychiatrists there, but let's eliminate psychiatrists right now. Any other resources or things that you think are useful, or put some kind of framework in that so that people that are listening can kind of say, all right, take this as serious as I need a paycheck and make ends meet, if that makes sense.
Yeah, I would really encourage everyone that's watching today is to really set aside some planning and solitude time. Okay, yeah, I'm telling my age now. I am a Stephen Covey a follower, and just starting out that morning every morning with that kind of solace. To give yourself that gift. That's my gift to the beginning of every new day. And then when I got to Rogers, check this out, y'all. I was never used to this before, but they actually block out. You cannot book a meeting in the first hour of the workday. From 8 o'clock to 9 o'clock is everybody's focus time. That's focus time as in on your calendar focus time, and nobody can even schedule a meeting. I'm like, if GE only was like that, because we had meetings at Jack at 7 o'clock in the morning, and that was East Coast time, which was 6 o'clock in Waukesha. But yeah, actually scheduling it into the day. And then guess what? Here at Rogers, it's even, they go one up even from there, where in the afternoons, you have this little ping, and I was just listening. I was hoping my notification's not going to come on during this call, where all of a sudden my screen goes to low light, and this meditation music goes on for about 5 or 10 minutes. I was like, this is so tripped out. But now I'm like, I don't know if I could work anywhere else, but that doesn't happen in the afternoon, just to give me some calm mindfulness time. And it's baked right into my calendar. More organizations need to be that proactive about ensuring that their employees take that kind of personal space time, that headspace. And now I'm speaking about apps now. So Headspace is one, Black Space Therapy is another one. Here in Milwaukee, take the time and share it with your family so that everyone in the household can also be well.
I'm jealous, Karen. That's awesome.
I'm working Rogers.
Right? You're giving me some ideas. I just to piggyback and add, culture is everything, workplace culture. So I don't have any great resources to add. I mean, Karen, those are fantastic ideas. But just from personal experience and observations, MHA supports companies around workplace mental health. And when we, especially the greater Milwaukee area, which is a little bit more diverse than other parts of the state, and one of the things that continuously impacts mental health and wellness from the perspective of professionals or budding professionals is the notion of belonging. And that could be gender, that could be race. For today's conversation, race and ethnicity matters. And so a lot of companies are, and this didn't just start in 2020, but it certainly was heightened. But companies are constantly in our community looking for increased diversity. The problem tends to be that they're often not ready. And so the culture is not ready to support. And so that impacts people's mental health and wellness profoundly, to the point that many folks are traumatized and end up not succeeding. But I just wanted to point that out, that culture matters when we are trying to support young professionals or folks who have been, there for a while. And I think we need to think about what that looks like, or what it could look like, and how that really, really profoundly impacts folks.
And I just want to build on that. Martina and Karen mentioned, culture matters, workplace culture matters, systems culture matters. I remember, I did 5 years as a police officer in the city as well. And I just remember, we have 2 in-services per year. And at those in-services, we're taught all kinds of things from first aid to just re-upping on our shooting skills to other things, right? Other speakers. And I remember even as we were there, we should be having something around mental health. We have an entire day that's dedicated 2 times a year to come into the academy. Why are we not doing something around mental health? Why are we not talking about what may be bothering us, what maybe we might be going through, what we're scared of, how our families are doing, how this and that is doing? I'm like, and there was this culture when I was there of, you know, if you talk about mental health, if you talk about how you're doing, or have to talk about that somehow, some way, that's weakness. And weakness on the street will not get you home. That was the psyche of like somehow, some way, being mindful or doing mindful classes or this or that won't make you aggressive enough for you to get home. And I think it's just the opposite. The longer that I went as a police officer, the more that I understood, if I don't address some of the trauma that I'm picking up, that I'm taking on, that's a more dangerous recipe, because that doesn't provide me clarity to think in those moments that I do need to have clarity. And sometimes a lot of these police officers will overly aggressively police when they don't need to, but because they haven't done their own work. And I think that exists much more than we understand it to. And I don't think that there's a lot of, fire police commissions. There's not a lot of chiefs. There's definitely not a lot of rank and file officers who are like, hey, you know what? Let me voluntarily go in once a month because I need to address some of this. Hey, let me get in service should be all about mental health. Let's get in a circle and talk to one another as police officers. Let's figure out how we're doing. And then all of a sudden things start to spiral before you can even catch it. And then what happens is you become a dangerous cop to society. So all of those things, all those different ways, there's ways that each and every culture, if it's policing, education, corporate, other ways that we could think about intentionally implementing mental health care into our systems.
Can I just say one last thing about that? Everything we said, all of us said is relevant. But to your point, Dr. Rodriguez, is that the reason people hesitate to share that they are utilizing those kind of supports in their life is because the system itself does not approve. And so the culture change that we're all referencing, it has to come from the top down. And so that's the message we could share ideas left and right today, but if it doesn't come from the top down and it isn't supported, then it won't be successful and it won't happen. And people will never feel like they can share or let folks know that they need support or are accessing that.
Yeah, and that's perfect. That's kind of how I wanted to lead into it, because it is where this uncomfortableness, this spectrum of what mental health is, now becomes, because it was, historical, it created disparities. The way we feel about things creates disparities. The way things are understood create disparities. And now you have disparities, and now there's we'll fix it, right? And usually it's we have program X, Y, and Z. Or, hey, we give money. Well, I can give $1 million for a lot of things, but that doesn't necessarily mean how am I going to fix it, right? So knowing those disparities that exist, what would things that you guys have seen have worked, or that are top down in terms of things like concrete, intentional? I like the word intentional when I speak in panels, because you do have to be intentional. It's not just going to sit on your lap. When it sits on your lap, it's usually a problem, right? But if you're intentionally going out to try to fix it, of these systemic disparity things, Pardeep, you mentioned there's tons of information, right? Yeah, you could Google mental health and you'll end up with more mental health stress trying to figure it all out, right? Versus what institutional things do you guys think should be happening to kind of close the gap here between that?
I'll just go ahead and jump in on that one. What I like about that word intentionality is people have got to put their money where their mouth is. So let's just go back a year ago, a little more than a year ago, when during the summer of social unrest, and Rogers is a very conservative, slow, methodical thoughtful planning kind of organization. So they were already looking forward to like 2022, 2023 to create my position and my department. But after the summer of social unrest, they pivoted quickly to say, oh, we've got to go ahead and hire someone and get this department off the ground. Hence the arrival of me and Jessica Kalango, my EDI coordinator. Once we are there, now also giving us the unwavering support from the very top, from the CEO, COO, CDO, Chief Clinical Officer, everybody, supporting the equity work to the point that now we can all sit back and say, ooh, we don't even know what we don't know when it comes to BIPOC mental health treatment. So what has happened in the past 10 months or so, especially in the last 3 or 4 months, with the advent of July being BIPOC Mental Health Month, is the creation of a BIPOC mental health treatment group of clinicians looking at what do we need to do specifically to answer that question, Dr. Rodriguez, because we can't just say, we're going to treat everybody the same. We're all just good people. We're going to just, we're going to love everybody the same, going to treat everybody the same. When a Black woman walks into a doctor's office and does her best impression of Fannie Lou Hamer and just says, I'm sick and tired of being sick and tired, she's not going to say, oh, I'm depressed, I've got anxiety. That's not the lexicon that is a part of the culture. So one of the first steps is to take that step back and get a dedicated group of clinicians to look at what is best for getting at that instead of that blase, we treat everybody the same. So that's one intentional thing that we're doing at Rogers.
Anyone else?
So at the height of, when the pandemic broke out, Milwaukee County the city of Milwaukee brought together community-based organizations, philanthropists, government folks, and we all kind of went and participated in topic areas that were pertained to social determinants of health. So I happen to sit on the mental health work group. And what happened was all the folks that needed to be together talking about solution-focused approaches and how to utilize dollars like we've never seen before and get them to the places that needed them the most. It happened in a way that really needs to be replicated in the behavioral health system. And so we did not start with the clinicians and the experts. We wanted to know who the trusted people were in the communities. And I think what that did is it shifted all of us who, quote unquote, professionals to take a step back and say, I can be a resource, but I don't necessarily have to be the frontline person. And so what has developed in our community, which it really is a beautiful thing, and truthfully, I never thought I'd see it, is that we are looking to community health workers, peer specialists, community organizers to go and connect with folks in the community. They're worried about PPP. They're worried about protection. They're worried about cleaning supplies, now evictions. I mean, I could go on and on. And what we know is all that impacts a person's mental health. And so now we have trusted individuals who are out in the community, listening to folks, and connecting them with the right resources. But when they know someone needs more than just a listening ear, they now have a team behind them of resources to say, I know how to connect you with someone because it sounds like you might need more support than I can offer. right? So we're not doing it from the top down. We're going the other way. And actually, those are the folks that in some ways know so much more than any of us. And so I think that is a model that needs to really be examined and funded and supported and evaluated and considered as to how we can shift what has become an ineffective way of serving people in our community.
I love everything you just said, Martina. In fact, I just want to do, I'm a both and kind of person. So in addition to everything that I've just described, we are also a part of our community intervention task force with Milwaukee and Waukesha counties. And that is a total coalition along with WISE Coalition, which is getting us into the community, and with the with NAMI and other community partners, because that's where you're absolutely right. That's where the real action is going to take place in terms of having those credible, authentic relationships in the community.
Yeah, and I would say, as a provider, and the example I would give is I think when I was in med school, it is probably the beginning, I would say, that truly the medical school curriculum started pushing cultural competency, because it's that term that okay, what does that mean, right? And how do you get that across with all cultures that we have? At that time, I remember two things. One, being Latino, being like, do I need this? Yeah, I do. But, in that, I'm just being honest. You kind of, the minority students were like, we get this. This is us. Why are we doing it? Which we didn't, because I don't represent every Latino that's out there, right? At the same time, the education, it was kind of this little like, it's a blurb. We just have to do it. And it's caught on, I think, in the medical school education. However, it kind of stops there. When I was at UW, kind of helping run the residency program, that was something I was committed to, because as we get into our careers, I don't know about you guys, but unless you're in that space, you really don't hear about it. So then it becomes, do you fall into your spaces? And the reason I asked that is one of the questions in the panel was, we are in Wisconsin, right? And I always debate that. Even I can tell you personally, I've had that thought where at times where I'm like, I need to go ask questions of someone, but I'm like, I probably call my LA buddies or my colleagues, because they get it. They know, they see, they have more diversity in there. Now, whether that's bad for me to think of, yeah, sometimes I check myself and I'm like, don't do that. There's still good people here. But, what are those qualities of providers that we look for to make sure that you can trust them and that they understand cultural competency is important and that you come from a different background, right? At the same time, then, for me, intentional is like providers. We right now in the emergency department, narcotics is a big thing. We have to do all this teaching. We have to do all these things. But never have I been dictated from a system to learn any cultural stuff other than in medical school. And I can't think in my other spaces of work where that's even been dictated. It's always been like, you're the only minority. Let's join the diversity community. But that's it, right? No one else is mandated to do anything else, which in my mind is like, how can we change that too? Going to how you guys were speaking of like being intentional from a company or from an education perspective. So any thoughts on that, or things that you have seen, experienced, not experienced? And then also to that question that the audience asked, like, what qualities would you say, hey, I know that I can trust them because they have X, Y, and Z qualities?
Great question. And I think that's one of the things that we think about when we think about good clinical work is therapeutic alliance. How much is a therapist or clinician or person who's directing services towards somebody else can connect? I'll give you just a short example. We had a kid, and I say kid, I'm talking about like they're still kind of older, but since I'm 45, I call everybody under 21 a kid. So this kid was struggling, and he got into sort of Muslim extremist ideology. Started watching beheadings and things like that when he was in 8th grade. Started to plan to create videos around pipe bombs and things, and then just got further and further into that and became a full-fledged sort of Islamist extremist. A phenomenal hospital, phenomenal doctor who had all kinds of credentials, took him in and worked with him for about a year, prescribed him medication, diagnosed him with depression, said he was doing this, that, and the other thing. And we get a call from his parents, and his parents said, like, things aren't working out. Can you guys work with him? And we've heard from his father, who basically broke down and said, and there's all kind of dual identity issues that are happening with this kid. He's got a white mother, he's got a Pakistani father. He's in his neighborhood that's a well-to-do, affluent area. He gets picked on. There's all kinds of other things, right? Worked with him for 4 sessions, 4. And his father said he's much more open. He's in a happier place. He's in a healthier place. And it just again, it came back to like, how much of a therapeutic alliance do you have with this person? Do we have clinicians who can have a relationship and can get cut past all that? We have a severe shortage of clinicians for people of color. I don't know how many times I get a call asking for a clinician of color who prescribes to children, or who's a psychiatrist for children, who specializes in that. We need to create avenues to have more clinicians of color. It's just, and I'm not saying that just only clinicians of color can work with clients of color, but I think that we really have to look at, if you're not that, you need to develop a therapeutic alliance, meaning it can't be experts talking to kids who are like, this expert has no idea on my Islamism, because he shied away, this particular doctor shied away from the Islamic part of it because he was scared, because he didn't have cultural competency around that. I didn't shy away from that. I knew that. I knew it. Like, I just, when he was telling me all this stuff, like, yeah, I get this, but this or that. And that corrective sort of like narrative can't happen when you have, it doesn't matter how. So I think that some of that cultural competency, when we think about the value of it, as we talked about, it was just something that was like this big and then became bigger and became bigger. I think it is the most important thing as a clinician, as an educator, as a police officer, in any systems. And if you want to be effective at what you do, you better be able to connect, and you better have some rapport and some relationship and some authentic knowledge. Otherwise, that other person will know you just don't. And I think that in this field needs to be something that all of us need to help people get to, but also we need to help other people understand their limitations in having that.
Right. And that is a good point in terms of, or like the term therapeutic kind of connection there, because it's changing it to, hey, we're buddies, or I have to have the same experience you do, right? Because that is limited. You're right. There's only far few between us. And what corporations or things that I've seen in my experience get to is like, well, we have one. So we've solved that issue. Well, no, because again, we can't speak. I can't relate to everything. And on the flip side, I would say, as let's say me personally, is knowing that, hey, it's a team. It doesn't have to be one person, and I can go to different resources to get what I need to get this mental wellness that's there, right? If I need medications, there's nothing bad with that. And if there's a person that can provide that, great. But if I need something else, if I need to vet something with a different person, that's okay to have. But it is that, right? Developing that. And for me, it is one of those, we talk about a lot of diversity, initiatives, and it's kind of developing the workforce, which it is, but it's also then developing those skill sets to then readdress those issues that we have within those communities, right? It's not to say, because we all know there is that term of like selling out, right? I hear it all the time, or at least it might be an inner city thing. Anytime I got higher, bigger, badder, like in terms of titles, everyone's like, you're selling out. And in a way you are, because you can't bring some of the stuff that you used to be able to do to the table. But at the same time, it is a perfect opportunity for you to influence those things, right? And a lot of times you don't have support, right? If you feel like you're not supported, you can have great ideas, but you're like, I just have a seat at the C-suite table. I'm glad I'm here. Now, C-suites might be a little bit different because you probably push some envelopes and push some agendas to get to that. But you know what I'm trying to say in terms of that concept of like that unsteadiness of like, how do I bring in my own experiences to do for it? So Karen, I know you're going to say something about that or mention.
Yeah, I love it. I love how you pivoted that, because, you're talking about brown nose. Let's just say it what it is. You're talking about, Uncle Tom and Aunt Jemima, and, somehow we've got to get past all that, so that even if we are the only one, we can still show up as our full selves, because number one of us is not all of us in terms of all people of color. I can only come with my own lived experience. I happen to be an African-American, Black person who is also Indigenous, who has the intersectionality of also being part Irish. So now go figure. So by the time I bring my whole self into the workplace and people just see Black, they don't even know the rest of who I am. And having been middle class all my life and all of that, the socioeconomic piece, that whole, we actually utilize the addressing model at Rogers. So everything from age all the way through to genders, as you saw me mentioning my pronouns during my introduction. I am working on what do we need to do to create a culture where people can bring their entire selves from A to G, okay, all the way through all the D's and all the S's and sexual orientation and everything, so that every part of me can be represented. And yet that's still just my lived experience, not speaking for the whole race. That's what I just wanted to add to that. Thank you.
Perfect. And so, we're kind of getting to the tail end of here, but I did want to, I think with the message of like, hey, there's a spectrum, like we talked about, there's different things to address on this. But I did want to get your guys's opinion of is, and it's kind of going through this part deep, I'm trying to say of like, this life coach thing, right? Like, so now I'm here. Now, one, I'm a corporate. I'm gonna have you do two things. One, I'm a corporation, and I listen to this, and now I want to do this. Like, it's not enough just to say I want to bring in more people of color, but I also want my Caucasians or the people of color that don't care to do. How do I get them involved, or who could I call, right? Because it's always, I can Google right now, and it's going to be overwhelmed with ads, with a bunch of I can help. But how do you go through all that to make something concrete? And the second part to the question is, I'm an individual in need of help. What are the things that you would say, ask yourself, so to better navigate that whole world of like, just call it the internet of like, I hit mental health right now. It's all over the place, depending on, and the Facebooks of the world, Instagram, they already know what they're going to tell you because it's based on all your research before, right? And so, but how do you break that? And what would you guys say?
Large scale. Hopefully, I think it'd just be nice to create a culture in society where we're better at listening to pain and not being offended by it, not judging it, but just listening to it, and then having a commitment to do something about it. It is within all of our personal journeys. It's part of all of our faiths to actually just bear witness to pain. And know that, so somehow, some way, even just bearing witness. And I think that if we can bear witness to somebody else's pain, we can look in the mirror and bear witness to our own pain. And listening to our own pain helps us navigate and say, okay, what is, what's going on with me? Why am I staying up at this time? Why am I waking up at 3 a.m. in the morning? Why am I eating this food that I'm eating? Why is it called comfort food? Why is like this? So all of those things, I think, asking ourselves of what we've been conditioned to do. And again, like knowing that the journey out is a journey towards personal and really this emotional freedom that we want to help everyone get to. And I say that I do think about young men and young men of color in this country have a unique journey. And I think that a lot of times there's this lack of awareness on what it means to be a man. Maybe that lack of awareness is because we're conditioned by media, we're conditioned by society, we're watching things and thinking to ourselves, how can I be bigger, stronger, faster, smarter, and all those things. But the thing that we got to come back to is, and think about it as a superpower is really vulnerability. And how we can be vulnerable and how we can utilize that vulnerability to get ourselves to a better place, as long as we are surrounded by people that we trust in the society that we trust. We will not get to a place of vulnerability if we can't trust the people around us, nor the society around us. And it behooves everyone to want to create that, because right now, to have communities of color, or even like new resettling Afghanistan refugees coming to this country and not having enough cultural competency around the way that they're going to navigate this country leads to not having those kids grow up and give back to this country. And so I think it benefits this country altogether just to make sure that we lay out a healthy fabric so that they can be adults that give back to this country, adults that help this country, and adults that give and that are healed and going towards a place of freedom.
Martina, any thoughts?
I was just kind of being reflective a little bit. So, this notion about mental health and wellness, and I think we focus a lot on the individual, which is important, don't get me wrong. But I think I can speak for all of us. We all want to live in healthy communities, right? And the way that we get there is certainly better access to physical health care, but also better mental health space. And so, to use your word, there has to be some intentionality around that. And so when you see your life coach example, I think it could go for being the life coach or from an organizational standpoint, that we really have to figure out how to respect each other's individual experiences. And so I think, I cannot speak for all of anyone, and neither can anyone else who's on the panel or listening. But really having an understanding that we all have lived experience and what that means. And then I mentioned this earlier. So we have diversity, right? We just need to be darn sure that we have a culturally responsive plan in place to maintain diverse staff and what that means, and to nurture their mental health and wellness. And then partnering with the community. None of us have to know how to do this all ourselves. And then my final thought about that is that we all need to function more with humility. And that goes back to that vulnerability piece that Pardeep was mentioning, and just being okay in that space of not knowing and being curious and questioning. It really opens an opportunity for all of us to grow and learn. I don't claim to know all of anything, and I'm always, interested in learning more from others, but it needs to be reciprocated.
Wow, that is so spot on. Both who I told you from the outset, this esteemed panel, oh my goodness, to be able to feel the pain, as you said, Pardeep, to be able to be culturally responsive, as you just said, Martina. What I am loving about what both of you said is that what that entails is wrapped into something that we do at Rogers with our compassion resilience. That's what you're talking about, is how do we really bring out that empathy, that feeling of pain, that actual, let me walk a mile in your moccasin, so to speak, in terms of having that be more of our approach in the mental health field versus, the saviorism of I'm, walking to my office and I'm going to save you from yourself. But how do we authenticate people's journeys and allow them to express themselves and let them use their own voices in describing what their pain is and finding that empathy and that compassion through it.
Exactly. I agree with you guys. And a couple of things like with Martina just said too, and you guys have mentioned it. And one is that vulnerability of being comfortable with it. And for people that haven't gone through it, obviously we've all probably done the work because we're in this space, both personally and career wise. It's a huge relief. And you can hear from me, and I can personally tell you, being in that discomfort, putting aside all those stigmas I thought, putting all those fears aside, when you really find someone in some space that you can do that really with, goes a long way. And I would argue it makes you a better person, makes your career, everything better, home, and make you a better person to then give back, right, and understand. The other thing I think is kind of Martina mentioned in terms of working within people, right? It's not necessarily a recreate everything, but using resources that are there and making those connections and bringing in those helps and learning from each other can go a long way. And I would like to kind of end it in terms of one, thanking the panel here, but also telling people like, yeah, we are in Wisconsin. And I always hear that where it's like, well, it's Wisconsin, right? We're not LA, we're not Chicago. Yeah, but we're here. There's enough people that are here in these spaces. There's enough people that need this, and organizations have to be responsive. Going to the responsive part, I guess, should have said that first, in terms of like, we do have a duty to be responsive. It can't just be speak about diversity when we know this mental part is there. And I think as soon as people know that that mental part doesn't mean like now you're going to put all your employees on antidepressive meds. That's not what we're talking about, but you're going to make them more productive, happier, and then the culture, it's all kind of downstream, right? In the emergency department, I see the opposite, the downstream effects of, hey, I'm desperate, I'm coming to you. And now it's a struggle to see the system kind of fail them, whether that's because of finances or availability of resources. And we can't think about it in that way, right? We have to think about it in a broader sense of how do we avoid getting people to that point, right? Why is it takes a lot for someone to come to the emergency department and say, I need help. But there was so many other opportunities where they could have had help. And there's so many other people that could have, things that could have been implemented so that it's not that stigma to get you there or that lack of access of care. So obviously this topic, I could talk forever and you guys could too. I appreciate your guys' time, and obviously the conference has to go on too. For what I told Henry in terms of, I think from these conferences, hopefully the audience reach out to people, and it's not to say that, if we can't help, we can probably provide resources, but at least get this conversation going. People use the people that are here. Oftentimes it's like, oh, I'm going to get someone from these bigger cities. No, you have experts right here that you can rely on and bring in to help, or even just to continue this conversation. So I want to thank you guys all. Thank everyone at 365, all the audience. Continue with the conference, and thank you guys again.
This is 365 Media.